Welcome to the BioBalance Healthcast. I'm Dr. Kathy Maupin.
And I'm Brett Newcomb. And today we're going to be talking about osteopenia and osteoporosis and why it is preeminently a feminine disorder.
Yeah, 10 million people in the United States have it, and most of them are women. 8 million are women.
Yeah. So 80% of the people that suffer from it are females. So I guess to have a cogent discussion, we have to start by defining our terms.
Not saying how unfair it is to be a woman. Yeah. Well,
we could move quickly over that. Yeah.
We get osteoporosis too, and we have the kids. So, in any case, what is osteoporosis basically should be discussed, and some people may not know what we're talking about. But osteoporosis is a thinning of the bones, and we measure bone density to see if you are thin or not, if your bones are thin or not, against 29-year-old females.
I have really thin bones.
You do? Really?
No, I don't think so.
I doubt it. Most men have pretty thick bones, even into their 60s. So they just start out with bigger bones and thicker bones. So,
but what you're talking about with women is you do a bone density scan to find out how thick or porous their bones are.
We're looking at the bone that's on the outside, not the bone that's on the inside with the marrow. Okay. So we're looking at the thickness of the outside ring of bone.
Okay.
And so that's done with a bone density machine or densitometer.
All right.
And that is a low grade or a low level x-ray, so low that people can stand in the room and not have to be shielded. Okay. So it's a low level x-ray that tells us how thin your bones are, but they compare us to a young female, which is exactly what we should always be compared to, because that's healthy.
Yeah.
So we're looking at bone density to see who's at risk after we turn 50 of having broken hips, broken bones, disabilities, inability to get around as we get older. So it's really kind of looking for a sign to replace something or to get on the stick and get treated when we're younger, like 40-something, and then we can be healthier when we're older and not be disabled. So that's the whole goal.
So the goal is preventative, to identify the people that might be at risk, and there are causal factors for that.
Right.
And to find ways to avoid it, or if they already are beginning the deterioration process, find ways to treat it, to restore the bone density.
That's true.
And when we talk about that, or when doctors talk about that, they are comparing the test scores that you get on density against a normal of a healthy 29-year-old woman. But they compare that data then in what is called a bell curve. And a bell curve is a statistical standard calculation that's used across multiple mathematical and scientific fields. And basically, the contention of the bell curve is that you start on one side at an equidistant from a baseline, and you go up at a certain predictable point and go across and come down and go off the same measured distance away. So what matters is if you take the center point at the top of the curve and you start moving out in brackets so you know where you fall, above or below the center standard. And they talk about standard deviations. So one measure out from center is one standard deviation. The second measure out is 2 standard deviations, and those are equal brackets. And the reason this matters is to make the distinction between osteopenia and osteoporosis. If you're 1.5 to 2, or 1 to 2.5 standard deviations off of norm, if your bone density is that much less than the normal healthy 29-year-old, then you have osteopenia, thank you. And if you're 2.5 or more, you actually have osteoporosis.
Now you've been a teacher before. Bell curves are what we're graded on, okay?
They used to. Modern teachers don't.
Grading on the curve means if you're between a D and a B, you're in the basic bell curve. But if you're in the outliers, if you're a D or an F, F would be osteoporosis, D would be osteopenia. So I think that's easier visually maybe for people to grasp, because most of us have been graded on the curve before, which I think is very unfair.
What's so unfair about grading on the curve, using the bell curve, is that it guarantees you have as many A's as you do F's.
Right.
Because you have to keep the standard brackets. So you adjust to find the center point, or the mean, mode, and median, of the middle, so that you have the standard deviations. So then you have
if you have a brilliant class or a subpar class,
yeah,
then
if you have a
it's
brilliant
not fair.
class of select pupils, 4 of them are still going to make Fs.
However, in bones.
Yeah, we're not doing education today.
No, we're not doing that, but we're trying to educate, but in a different way. But in bones, if you are in the outlying portion, if you're thinner in the group that's thin and you have osteopenia, that doesn't mean you're going to spontaneously break a bone. It means that you are at risk for developing osteoporosis, so we need to treat you.
Right.
And if you're in the osteoporosis area, that's pretty bad. You could step off a curb and break your hip, your leg, or you could fall on your hand lightly and break your forearm, which is the most common break of osteopenic and osteoporosis.
Not a hip.
No, because most of us first, before we break our hip,
Start to fall and break your
when we have osteoporosis in the very beginning, we're just starting. This is the thinnest bone. It was a smaller bone to begin with. Our hip is a little thicker, but it's getting thin. The first sign is we break our forearm by falling on it, and so that is a sign of osteoporosis. You could be in a terrible accident and have it broken, but if you just fall off of a step or something, break your forearm, you probably have osteoporosis.
All right. So if I take the test and I'm starting to drift off of normal to the negative side, so that my bones are being less dense, and we recognize that early, there are treatments for it. So what are the things that you can do to prevent the continuing deterioration?
Well, there are lifestyle changes and supplements, and everything depends on both what the patient does and what we do for the patient. So that's kind of a truism.
So diet and exercise, weight bearing exercise.
You have to exercise with weight, not swimming. Okay. So it has to be something like biking or running, walking, something where your weight Stairmaster, where your weight is on your long bones or your hip and your legs. So that's weight-bearing exercise. That should be encouraged daily or at least 3 times a week at the minimum. And vitamin D supplementation, you should get your vitamin D level above 40. And that sometimes is hard, so we have to do blood tests for that. That means you're going to be able to absorb the calcium in your diet and put it into bone. So that's the second thing, and then you also have to have calcium. It's kind of like a plant. Everybody says, well, if I take calcium, I'll be fine. Right. Well, if you have a plant and you put it in a pot of dirt, but you don't put it in the sun and you don't put water on it, it's going nowhere. So are your bones. If you take calcium and you don't take vitamin D and you don't have any hormones, that's another thing we haven't talked about yet, but and you don't exercise, you're not going to get your bones back. They're just going to deteriorate more and more, because every year after you have osteoporosis or osteopenia, your bones deteriorate 1% per year. And as they get smaller, that percentage is a bigger number.
So that tick, tick, tick that you're hearing is actually your bone density just falling away.
Not mine.
Not
Mine's
yours,
great.
because you're doing all of those things.
I'm doing those things, and I take testosterone. So basically, getting older is why one of the reasons why we have thin bones, but also poor diet, poor exercise, and also genetics. Some of us are born with thin bones. Some of us are born with thick bones. Now, men are always born with thicker bones than women because they have more testosterone, so they genetically and developmentally have thicker bones. So men also have testosterone longer and a lot more of it. So you rarely see it in men because of that reason. But
yeah, when we were preparing this podcast, I asked Kathy, what's the best way to avoid that? She said, be a man.
That's true. That's the best way.
Yeah.
So in any case, if we can do all of the things we do in terms of being a patient, and then if your doctor can also partner with you and replace your hormones, then you might not need the drugs they came out with for osteoporosis, because those drugs have a lot more side effects than just replacing hormones.
And they're really starting to see this because we have a comparative treatment. And when you only take the Fosamax and that's the only thing that's available, you don't worry as much about what might the side effects be, because you got to have the treatment. But if there's an alternative that gets as good or better results without the side effects, you obviously want to know that.
Yeah.
And part of what compounds this problem is that it is a problem of aging. Both in terms of the deterioration at 1% a year of the bone structure, but in terms of the change in the focus and lifestyle patterns of the individual. They do tend to become more sedentary. They do tend to eat perhaps less well than they should, not necessarily out of choice, sometimes out of economics. You get people that can't afford to do that. They have not only the aging process for bones, but also the aging process for hormones.
And that's why your bones start deteriorating when your testosterone drops. So in women, our testosterone drops more in our 40s
right.
and thereafter. So our bones start thinning out between 40 and 50. It's not when we hit menopause, although that compounds it because estrogen builds bone as well. So I had to see a doc for rehab. I had lifted weights. I had lifted too heavy a weight, and my doc looks at my X-ray, and it was a cervical spine, which is up here. And he looks at it and he yells to his tech, "This is the wrong X-ray. This is not Kathy's." And I'm looking at it, and he didn't have his cheaters on, of course. So she comes in. She goes, "That's the only cervical spine I've done this morning." So he looks at it real close, and he says, "Your bones are so thick." This is about 7 or 8 years after I'd started taking testosterone. Your bones are so thick. He said, "I can't believe it. I want what you're having."
Wow. Which, interestingly enough, is the name of your book.
Is the name of my book. Yeah. But a lot of people say that.
Yeah.
So, and not just to me, but to my patients. So, in any case, I'd never taken a bisphosphonate, partially because I was wary about. There's a very rare but very severe problem with jawbone ossification, and sometimes people lose their jawbone from bisphosphonate. So I find that to be a risk I didn't want to take. But I did have osteopenia when I was in my 40s before I started taking testosterone because I was on a drug called Lupron, which puts you into menopause years before that for infertility. So I did have osteopenia. But once I got the testosterone at 47, my bones all came back.
Okay, so you raise an interesting point. If you replace the testosterone naturally, early enough, the beneficial aspect of having testosterone restores the strength of the bone. You were talking off camera about one of the side effects of the drug, the bisphosphonate, is that they're starting to have questions about whether or not what looks like a dense bone on the bone density test is in reality a dense bone, or it's just more of a crust around the bone, but the bone is still brittle and thin.
The medications came out about 15 years ago, and so we don't have a really long time frame for looking at people, but now that they're finding people who have been on this for a long time, they're finding that they're still getting breaks. They're still falling and breaking their bones, even though their bones look great on a bone densitometer. And so the recent studies have proven what I suspected, that it wasn't as thick or strong a bone. It looks good on X-ray.
Or at least that there's a legitimate set of questions about it.
Right.
I mean, you're not saying that Fosmax doesn't work and you shouldn't use it.
It does work.
You're saying that there may be some camouflage issues that need to be studied further.
Right.
And that those issues are not raised by the replacement of the hormones testosterone and estrogen.
That's right. So you kind of pick your risks.
You pick your risks. But that's what being a good medical consumer is all about. And that's part of what we talk about in these podcasts all the time, is really, really important for you to be an informed consumer and to have a relationship with your physician so that you can have these conversations to say, explain to me, clarify for me, what are we looking at, how do I understand it, so that you can then make medical choices that are the best optimal for your unique circumstances. It's
That's
not
right.
one size fits all medicine.
No, it isn't.
Yeah.
It isn't. So I guess most of my patients come in and say, why didn't I hear about osteoporosis up until 15 years ago? And that's because we didn't have a really good drug besides hormones to take care of it. No one recognized hormones as really the thing that was keeping women's bones better. And we only used estrogen and not testosterone. So basically, it became a new interest for physicians, something they could do to prevent future illnesses. And it was marketed well by the company that made Fosamax, and then the other companies that followed. that made all the other bisphosphonates, Actonel and Sally Fields one. The one that Sally Fields advertises.
Sort of a serendipitous effect of the pharmaceuticals discovering, you know what, this medicine solves this problem, is that then allowed doctors to say this is a problem that we need to be conscious of because we can treat and repair or prevent issues from arising.
And so in that way, it was really good. It educated the public by putting their marketing on television, and people started asking questions, and then doctors started checking with the bone density machines how the bones were in all of their patients over. It used to be 45, now it's 50 because
kind of like the space program led to the invention of Tang.
Yeah, okay.
Actually, the
I forgot
logic
about
is
that.
consistent.
That just told everybody how old you are.
I have some dense bones.
Yeah. Okay.
But if you have questions about osteopenia and osteoporosis, that you should get information about it. You can talk to your physician about it. You can do some research. If this podcast is not giving you the information that answers your questions and you want to contact us directly to get better answers or additional answers, you can do that. And how can they do that?
You can go to my website at biobalancehealth.com, or you can email us at podcast@biobalancehealth.com, or you can call my office at 314-993-0963. We'd be glad to see you.
And you can always reach me at brettnewcomb.com.